So he has been either a co-investigator or principal investigator of quite a large number of clinical trials. So he's going to give us a talk on the management of lung cancer beyond drug resistance. So let's welcome Dr. Lee.
Good evening, everyone. It's my pleasure to be able to stand on the same stage with our scientist, Dr. Chen, and also our respiratory physician, Dr. Matthew Wong. In the next 20 minutes, I would like to share with you my little experience on how to manage lung cancer in a precision medicine way. It was a miracle that we are not unable to achieve in the past. A patient dying, oxygen-dependent with bilateral lung carcinomatosis upon detection of a sensitizing mutation on the plasma EGFR and put on the appropriate TKI. In just less than 4 weeks' time, returning a dying patient to one with good well-being, good appetite, and oxygen independence. And that has to thanks to the improved understanding of lung cancer genomics. In the past, we know nothing about adenocarcinoma, but now we know that for each of the adenocarcinoma, they can be different. Each one of them may have a different driving force to induce tumorigenesis, the uncontrolled tumor growth. Everyone knows about the EGFR out and ROS1 mutations, but now we're talking more and more those uncommon mutations. The MET amplifications, the exon 14 splicing mutation for MET, the ROS1, the BRAF, the HER2, or even the PIK3CA. The first we know is the dibrafenib with plus a trimactide combination in BRAF V600E mutated lung cancer. It achieved FDA approval starting in June this year. In the phase 2 trial of 60 patients, it demonstrated a response rate of over 60%. The use of a BRAF inhibitor alone would paradoxically activate the MET pathway and cause a lot of side effects. And the concurrent use of trimactide can obliterate that problems with especially reducing the incidence of cutaneous squamous cell carcinoma. For MET dysfunction, it encompasses both amplification and exon 14 splicing mutations. That exon 14 splicing mutations would lose a protein that binds to the ligase responsible for the CMAC degradations. Once that protein is lost, that would be increased the occupancy of the MET receptors. Currently, we have a quizartinib or carbonsatinib that may target the MET pathway, but I think the eventual winner would be an agent called INC280. In the initial studies, they found a response rate of over 40%. And with the ambitions of the company, probably they would conduct a phase 3 study on that particular group of patients. The RET translocation is a bit disappointed. So far, among these RET inhibitors, you can find only response rate of 20 to 50%, and just acceptable progression-free survival from 4 to 7 months. Although alectinib has certain degree of activity on RETs, I think they are on the way of developing trials using high dose of alectinib, 1,200 milligram BD. And I think they would eventually win in this pathway. Recently, people talk about the anti-RK pathway, the neurotropin tyrosine receptor kinase ABC, which encodes the protein TRK ABC. The agent entrectinib actually target only the anti-RKs. Anti-RK exists only in a small quantity incidence, 1 to 2% among all solid tumors, not only lung cancers. That agent has also a good CNS penetrating property, and that the figure here shows you a good responder. These are the sequence of therapy that I suggested based on most of the available evidence, my personal experience, the treatment toxicity, and also the financial concerns. Everyone knows for sensitizing EGFR mutations, out and washout mutations, you should do it in the upfront situations. But for BVAF V600E, although the FDA approval has low restriction on the line of therapy, I advise you to do it in the second line situations. First of all, it's based on just phase 2 study with 60 patients, and also the cost is so high. For combining dabrafenib with trametinib, you cost around $135,000 per month at the recommended dose. For MET dysfunction, although there is no available phase 2 data, but we know that for MET dysregulated cells, the response to the second-line docetaxel is very poor. It's less than 3 months. And we just know from EXCO this year, MET dysregulated tumors has very poor response to immunotherapy. The response rate is quoted at 6%. For RET translocated tumor, HER2, I will use it as last resort. For others, you should put it in the clinical trials if available. No matter how good the initial response is, all these pathways would develop acquired resistance eventually. Taking EGFR TKI as the examples, we can see that among all these phase 3 studies, the progression-free survival for the target agent is kind of fluctuating around the figure of 11 months, with a better converge to 11 months for the newer studies, probably because a better understanding of the mutation type. Not all mutation is sensitizing. For example, IPAS, they include also exon 20 insertions. To echo the topic today, the goal beyond resistance, I try to divide the subsequent slides into 4 parts for better understanding. In order to go beyond resistance, you have to know what are the resistance mechanisms and what is the prevalence of those resistant mechanisms. Again, take EGFR TKI as the examples. Majority of the mutation is T790M mutations. It's just a single protein mutations, and that has 2 effects eventually, from trending from phenylalanine to the methionine at the exon 20 T790M positions would convert increased ATP binding and relatively resistant to the first and second generation TKI. It also creates steric hinges that does not allow the binding of those EGFR TKI. And there are also others quality resistant mechanisms, HER2, MEK, PIK3, C8, MEK, K1, BRAF, and some morphological changes. We can also group the mechanism according to this way. It could be a target alterations with T790M mutations, plus or minus amplifications. It could be a bypass pathway with MEK amplification, HER2, HER3, IGF-1R. It could be some downstream pathway, BRAF, MEK1 amplification, PIK3 mutations, or loss of PTEN. It could be also morphological changes, just a small cell lung cancer transformation or epithelial mesenchymal transitions. The understanding of the acquired resistance is of paramount importance in rationalize the use of drugs if it's not in the standard way. This example of effectively cetuximab well illustrated that. In this study, around 200 patients are being recruited, and the dose at the expansion phase is effectively 40 milligram daily, cetuximab 500 every 2 weeks. And they achieve a good response around 30%. It is similar among T790M positive patients and T790M negative patients. However, there's a caveat in this study. It does not restrict patients with immediate TKI failure, because we sometimes observe a called retreatment effect. If you put a patient on first-line TKI and you wash out with chemotherapy, let's say pemetrexed, carbopactin, and then docetaxel, and on the 4th line, you put back on the same EGFR TKI, a significant proportion of this patient would get treatment response. It could be up to 10 to 20%. So among these 30% responders, some of them are just because of retreatment effect. And if you believe in the theory of that combinations of pan-HER inhibitions using effectively pacitumab, if you get a chance to get those tissue and send it for NGS, and you can know what kind of acquired mechanism exactly it is. If the mechanism is something that's related to HER, then that should be that probably can work. But if some mechanisms other than that, it's unlikely to be helpful. If you have a MET amplifications, if you have IGF-1R mutations, that pan-HER inhibitions has no reason to work. The original study only tests on T790M mutation, but without looking into others rare acquired mutations. You also need to define accurately what are the resistancy. This is the commonly used criteria called Drakman criteria to define TKI resistance. For defining a resistancy, you have to be on the TKI only. You have to achieve the long benefit with PR or CR or proven benefit of disease control at least 6 months. And then eventually you have to demonstrate that radiological progressive disease according to the RECIST or WHO criteria. And you shouldn't have any treatment interruption for more than 30 days. The last one is very important. We observed a phenomenon of tumor rebound upon stopping TKI at the time of disease progressions. 3 weeks after the stopping the TKI, you see the accelerated growth of the tumor. And if you're putting back the TKI, you can put back the sensitive cone initially back to the quiescent state. The aspiration study is a reminder to tell us that some patients do not need to switch therapy at the time of progressions. By continuing the drugs beyond progressions, as long as the investigator feel comfortable, you can extend the progression-free survival by 3.7 months. Although the study does not address properly the overall survival issues, it is always a good reminder to us that some patients really progress very slowly. I have patients that progress radiologically according to RECIST with little lesions or enlarging lesions, but then it stayed there for like 2 years without any further progression and no symptomatology as well. We also need to know there are 3 types of progressive disease. It could be a systemic progressive disease. You have a disease progression everywhere. You could have oligoprogressive disease with progression of only less than 3 or 4 sites, which is assumed to harbor the resistant cone. By ablating this resistant cone, you can continue the same agent without switch. There's also something called CNS progressive disease. It's because of poor blood-brain barriers. For example, erlotinib only has 3 to 5% CNS penetration. For gefitinib, 1 to 2. But now, as we have more and more target agents with better CNS penetrating property, like osimertinib, we have 30% CNS penetrations. Quizartinib, 0.5%. But now alectinib, again, together with lorlatinib, is over 30% CNS penetrating. So in the future, you can see less and less this CNS progressive disease. Eventually, it could be just a spectral type of oligoprogressive disease in the middle. We also need to detect the resistance accurately. But remind you that among those acquired resistance in the case of EGFR TKI, only T790M mutations has FDA-approved subsequent therapy, osimertinib. But most other agents, they don't have any approved therapy. Small cell lung cancer transformation is a special category which you would expect a high chance of response by the use of etoposide platinum. And because it is the only mutation with proven approved FDA therapy, you should find it as hard as possible. All three establish the role of osimertinib after EGFR TKI failure. Patients in this study are randomized 2-to-1 into osimertinib versus platinum pemetrexate. And you see an overwhelming support the use of osimertinib over platinum pemetrexate. The gain in absolute PFS is more than 5 months. The hazard ratio 0.3. However, there are so many methods to detect the EGFR T790M mutations. And each of them have a different analytical sensitivity and different areas of applications. And nowadays, in the recent hot topic, we're talking about use of a liquid biopsy to detect most of the mutations as an alternative to tissue biopsy at disease progressions. And it even allows serial monitoring of drugs for a disease recurrence. It has been proven by some genotyping studies whether you detect the T790M by plasma or tumor, you get the same progression-free survival. And only in patients with plasma T790M negative disease, you have to do the tissue biopsy because there are 30% chance of false negativity. By doing that, you can still pick up around 30% of patients that would attain a significant benefit from the use of osimertinib. When you compare tissue versus plasma with biopsy, each one have their pros and cons. For tissue biopsy, you can only biopsy one site at a time. For the plasma, you can theoretically sample all tumors that secrete cell-free DNA, and it's supposed to be the one that is progressing. By biopsy of more than one site, you can potentially capture tumor heterogeneity, but not all patients are able to provide an adequate biopsy at the time of progressive disease. But for plasma, it's a simple blood taking. You can test it on all patients, and it allows serial monitoring for emergent resistance and response to third-generation TKI. For tissue biopsy, you can capture all resistant mechanisms, not only the T790M MEK HER2, morphological changes, small cell lung cancers, transformation, or epithelial mesenchymal transitions can be picked up. But for plasma, usually only T790M mutation as the only target. For plasma, you need a very highly sensitive assay and with lead experience and also cost as the implications. And sometimes the sensitivity of the plasma testing is limited. It's because of tumor biology. Sometimes, no matter how, the tumor just does not secrete the cell-free DNA. And it's known that using the formalin fixations, you can artificially create some false positive T790M mutations. Just a kind reminder that T790M mutation is a simple cytosine to thymine transitions and is very prone to the deaminations by the formalin that you use it to fix the tumor, FFPE. ACG for the thymine is the only coding sequence for thymine. For the ATG is one of the encoding sequence for the methylene. By simple C to T conversions, you can create T790M mutations. In one study using paired samples, they use a mutant-enriched PCR with 0.1% sensitivity. You detect 50% the low-fold T790M mutations. But on the same paired samples, using fresh specimens, there's no mutation at all. So if you find some study reported a high incidence of the low-fold T790M mutations, you have to look carefully whether they are using a more than necessary ultra-sensitive method for detections, and whether they use fresh samples or FFPE samples. The following are the time points that I recommend for rebiopsy. We all begin with the oncogene-addicted lung cancers and put on first, for example, using the EGFR mutation as for illustrations, put on first or second generation EGFR TKI. And at the time of progressions, as long as it's not oligo progressions, in which case we don't need biopsy, you just abrade the tumor. After exclusions, we do the biopsy, be it liquid or tissues. You detect the if any T790M mutation, if there are T790M mutation, you use osimertinib, and upon the time of further progressions, you may consider biopsy again to look for the common C797S mutations, and also the loss or gain or persistence of the T790M mutations, and making a kind of combinations that allow you to choose whether you can try back the first generation TKI or using it in combination with a third generation EGFR TKI. The fourth generation EGFR TKI EA1045 is still in develop. We don't have the chance to use it. We doesn't have any chance to use it. And in some time you can pick out a mechanisms other than that and allow you using other target therapy like MET amplifications. But of course, there's no solid evidence on that. For the out-translocated tumors, there are two approaches of using. It could be a sequential approach using the quizartinib as the first agent, or using the upfront approach with a better second or even third generation out inhibitors, alectinib, brigatinib, seratinib, and nolatinib. And upon the time of disease progression, you can do the biopsy and look for the possible mechanism of resistance. More than around half of them is related to the out gene itself. And if you use it on the cellular models as a tooth, you can use you can choose the more appropriate second or third generation out inhibitor according to the profile. Finally, you have to choose the best available next line of treatments. But unfortunately, there is still not yet any strong evidence of any of this. And there will be a concern of treatment toxicities. Most of the time, people advocate the use of combination therapy with the EGFR plus others. The others is the some of the long T790M mechanisms. And also with more than one agent, the financial toxicity is a concern. Finally, I want to give you a few examples on my way of practicing precision medicines. There are 2 cases of liquid biopsy on non-cancer patients and 2 cases of tissue biopsy on GBM and non-cancer patients. For the first case, is a PIK3CA case. Lady, 66 years old, relapsed with poor effusions, full metastasis, and put on the first line erlotinib. And at the time of increased tempo of progression, we checked the digital PCR liquid biopsy and detected exon 20 mutation at low quantity. But still, she was put on the osimertinib. At the time of further progressions, I ordered the monitor lungs from Genomics as a form of liquid biopsies. The report compared to the PIK3CA mutations, along with the original mutations. PIK3CA is a kind of downstream mutations that is known to be resistant, making the EGFR receptors resistant to EGFR TKI. So there's no hope of trying the original first line TKI. And therefore, I advise the patient for chemotherapy. Initially, she's very reluctant to try chemotherapy. That's why I ordered the liquid biopsy. The second case is a 72 years old male, liver smoker. He has ALK positive adenocarcinoma of lung. Tried the chemotherapy, pemetrexed, carbopactin, maintenance, pemetrexed, and at the time of progressions, switched to quizartinib with some response, and on further progressions on alectinib, again with initial response, but eventually progressed after just 5 months of treatment. At that time, I ordered the liquid biopsy using Garden 360, and this is the profile. Apart from the original EML4 ALK fusions, we find there's L1196M mutations. In fact, this is very common mutations after quizartinib failure, but not that common after alectinib use. And if you're looking at the profile, the mean IC50 of all these agents, 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 the mean IC50 This is L1196M. Although it's to a certain degree sensitive to alectinib, but theoretically it's more than 10 times more potent if you use seralutinib. So in that case, for that reason, I'll try to put the patient on seralutinib, but at a lower dose because he's 17 years old, at 450 milligrams. But there's still a lot of side effect from that dose reductions. Even I reduce it to 300 milligrams, he still got quite a lot of GI upset. But it seems like that drug is not useful at all. Eventually, it progressed after just less than 2 months treatment. That case demonstrates to you, although clinically, in preclinical data, is sensitive, but in reality, the toxicity of an agent would limit your full dose use. The third case is a GBM patient. She is a young 24 years old female with brainstem GBM, MGMT negative. She received standard chemotherapy and radiations, adjuvant chemotherapy as the STUP regimens. At the time of, after 3 cycles of adjuvant chemotherapy, she developed progressive disease. This is the original tumor. But the tumor progressed with upper cervical extensions. In fact, I have ordered the tissue biopsy for Foundation 1 right at the time of diagnosis. And if we look at the report, in that report, we find there is a fibroblastic factor receptors, N4, N546K, and a lot of amplifications. The first impression of this report to me is there are too many mutations that I don't know which one to target on. And also, I think there may be a tumor heterogeneity. How come there's a tumor with so many types of driving mutations? But in view of lack of a useful second-line therapy for GBM, I eventually put the patient on paxlovid. Not only paxlovid targeting the fibroblastic factor receptors. In fact, paxlovid has also anti-VEGFR property, and we know that bevacizumab and anti-VEGFR antibody has been commonly used in GBM patients. And after just 2 months of use, there's indeed really treatment response. We see the tumor is shrinkage at the brainstem areas, and the cervical tumor is also less enhancing. However, because of tumor heterogeneity, the effect is just short lasting. After 5 months of treatment, the tumor extending to the right thalamus. This is the right thalamus. It's getting bigger and bigger with extension superiorly. But for the original tumor and the upper cervical tumor, it remains well controlled. This is tumor heterogeneity. It's intratumor heterogeneity. Upon failure, I put her on a macrolide temozolomide, but it's failed eventually. Case 4 is a bit straightforward. It's an adenocarcinoma of lung with brain and lung metastasis. He received earlier carbopectin whole brain irradiation and disease under well control over 1.5 years of nivolumab. But eventually he progressed with multiple brain met, received gamma-light radiations, and but on PET-CT there's a generalized progression. In fact, we have we have sent his tumor tissue to Foundation time right at the time of disease diagnosis. This is the report. In that tumor specimen, we found there's a BRCA mutations, ELI02, and it's a somatic mutation. Because I sent the blood for germline testing as well, but it's negative. So it's just a pure somatic mutations in that tumors, and there's a lot of other amplification as well. I'm so much eager to put this patient on olaparib, but it's not that possible under the public hospital setting. Eventually, I referred the patient to the private sectors, and they just started the olaparib. And I'm so much eager to try it, to see the treatment response. This case shows you the restriction of the Hong Kong doctors. When you use some agent that is so much uncommon, then it's the liability of the doctors. Then in case anything happened, that could be the liability of the doctor. So for the summary, the practice of precision medicine led a thorough understandings of all oncogenic pathways. Evidence evolves slowly and remains immature, but valuable in patients exhausted all existing treatment options. Tissue and plasma with biopsy are complementary to each other, but none is gold standard. Cause, legal issue, treatment toxicity, and tumor heterogeneity are always the issue in selecting drugs, not only in the primary first-line setting, but also at the time of overcoming acquired resistance. So thank you.
So our next speaker is a real giant in the advocate and implementation of NGS in precision oncology, because she's the co-founder of the ACT Genomics. So a very important company that will bring NGS applications to the field of oncology. So I think most of us know Dr. Chen, so I'll just give a very brief introduction. So she got her PhD degree in biochemistry from Virginia Commonwealth University and did her postdoc training at Bayer College of Medicine. And after that, some years in research, and he returned to Taiwan and co-founded the ACT Genomics together with another Dr. Chen, and now he's really important in the development of precision oncology and NGS applications in Asia, and including Hong Kong, of course. So without further ado, I'd like to welcome Dr. Chen to give her talk on the NGS in precision oncology for lung cancer management.
So after the previous two talks, now I know why all the samples, particularly for lung cancer samples that we receive from Hong Kong, is really difficult and also very interesting. And that's because you do have a very good method to obtain tiny amount of tissue, and also have a lot of sample that has a lot of patients that have been treated multiple lines. But nonetheless, I'm just going to use the next couple of slides to show you the clinical application of next generation sequencing for lung cancer. And this is just some example to show you how to use this technology and the data to manage patient from treatment to monitor. And of course, this is my disclosure. And just quickly go through, we know that cancer is a group of genetic diseases. So all of those mutations associated with cancer can be used as a very specific diagnostic marker, but most importantly, they can also be used to guide the treatment. And this is particularly true in the case of lung cancer. In fact, lung cancer is probably one of the disease type that has the most targeted therapy available. And so, of course, we already know through Dr. Lee's introduction, we know a lot about genetic alteration in lung cancer. So this allows us to specifically design the targeted therapy based on patient's mutation. But if we look at the field for a targeted agent developing for non-small cell lung cancer, you can see that this is actually a very crowded area. And so we can anticipate, not just now, but also in the coming future, we need to have a really thorough understanding of patients' genetic alteration, and so that we can select the best treatment option for the patient. Before most of the treatment option, we need to rely on FFP samples. And with so many different targeted drugs available, And we have to go through so many different genetic alterations. If we do it by the conventional way, one by one, pretty soon we're going to exhaust the patient's tumor and sample before we hit the right target or the right alteration. So in order to realize the goal of precision medicine, I think we do have to have a way to quickly and also thoroughly interrogate the genetic alteration in the tumor. So next generation sequencing actually provide a method that allows us to use tiny amount of sample and can simultaneously sequence hundreds to thousands of genes, so that we can use this technology to detect many mutations. Also, next generation sequencing also allows a much more sensitive detection if we talked about sequencing. So throughput as well as sensitivity is actually what makes next generation sequencing very useful and variable in the clinical setting. We will be able to use tiny amount of tissue and go through hundreds of thousands of genes and find the mutation for the patient. And once we can stratify the patient with the genetic information mapped with medical informatics, we ought to be able to select a better treatment option for the patient. And this is the goal and also our dream for precision cancer medicine. And of course, as Dr. Lee mentioned, we're still quite far away from realizing the dream, because any treatment, of course, is not going to give you 100% response rate. And all of the targeted therapy is not going to last forever. Typically, patient will recur. So the goal of precision medicine is not just to treat the patient, select the best treatment for the patient at one time, but also to help to manage the patient as the disease progresses. And so we know these are all the genetic alterations associated with non-small cell lung cancer. And there are a lot of mechanisms associated with acquired resistance for EGFR TKI. And there are so many different mutations. Some mutation can confer sensitivity, while other mutation can confer resistance to different TKI. So that is why we need to have a very thorough understanding for patients' mutation. And here's the why when we perform the next generation sequencing to select patients' treatment strategy, we actually need to have a really, really good quality of data. And so typically the next generation sequencing is done like this. First of all, you collect the sample from patient. This could be tissue, could be blood. Then you extract DNA, but typically you would just send a sample. But as you have seen all of the pathology sample, most of the tissue are not 100% tumor. In fact, a lot of tissue that we got, the tumor purity is actually below 20%. So in order to get a really good data, we typically will perform macro dissection. So first highlight the tumor region, then enrich the tumor region before performing the sequencing. And so this way we will be able to detect even those very rare mutation, no mutation present at low allele frequency. And then we have to decide what kind of genes or which genes that we would like to sequence. And once we obtain the data, if the sequence steps is not deep enough, then your sensitivity will not be enough to detect those also low allele frequency mutation. So typically for tissue, we will sequence at least 800 to 1000x. And for blood, we typically will sequence at least 8,000 to 10,004, so that we have enough sensitivity to detect mutation. And finally, we have to perform data analysis. And although most of the data analysis typically just map one single gene and one particular mutation at a time, but we do need to remember all of these genes are existed in a pathway label. And so you do need to look at all of the mutation and genetic alteration along the same pathway to understand what kind of pathway alteration is present in the patient, so that you can select the best treatment option for the patient. So typically, although for lung cancer patient, a small panel of targeted sequencing is good enough, but in some case, a large panel will be more appropriate, so that we understand what the hallmark of cancer is present in the patient and can select treatment accordingly. So I'm just going to use next couple of examples to show you how we can use this type of sequencing to help oncologists to manage their patient. Typically, lung cancer patient can be easily diagnosed based on targeted-based treatment selection. So you sequence all of the drug targets and see which drug target was mutated or amplified. And then based on this information, to identify the best treatment option for the patient. So this is very similar to conventional companion diagnostic, except this is a multiplex companion diagnostic. So we no longer have to test EGFR first, then followed by ALK mutation, then by RAS1, and one by one. We can simultaneously go through all of the genetic alteration or all of the targetable drugs. And so this is an example that we sequence a patient, and actually you can typically see that this patient has EGFR mutation, and both mutations are sensitive to conventional TKI. So this is a very straightforward mutation. But this patient also has T790M mutation. And so when the patient was present with both sensitive mutation as well as resistant mutation in the same tissue, based on the allele frequency, we can know that majority of tumor in tumor cell in the patient's tumor has already developed resistance to first generation TKI. So for this particular patient, it's probably very important to use third generation TKI because most of the tumor cells are already resistant. And of course, you can also look at other alterations. So this is an example that patient actually has HER2 exon 20 insertion. And so these are very typical mutation that we see. And of course, this is a very different patient. So this patient actually has been treated with first generation TKI and developed resistance, being treated with third line TKI, developed resistance again. So what to do? We actually sequenced the patient with whole exome just want to know what happened to the patient. And it turns out that the patient's T790M mutation was gone, completely gone, and we could not find any other alteration. This patient actually was put back to the first generation TKI and actually responded quite well. So before, we typically would look at just one gene, but with even a smaller panel simultaneously looking at multiple targets, we will be able to determine the best treatment or better treatment option for the patient. So this is what we expected, and very typical. But is lung cancer as simple as we thought? Like all the patients will actually have very straightforward mutation. So this is an example of patient who was treated with Alimta and cisplatin and actually didn't respond. So we got her brain met FFP sample and performed the test. This patient actually has red fusion. So again, in addition to genetic alteration at DNA level, we can also look at the RNA level to detect fusion transcript and decide the better treatment option for the patient. And this is another patient that we actually used actually use his polar effusion cell blocks. So when the patient cannot offer, for example, tissue sample, polar effusion cell block is actually an option. So once we make sure that their tumor tissue in the polar effusion cell block, we went ahead and sequenced the patient. And this patient actually turned out to have ROS1 fusion, 2 different ROS1 fusions. Luckily, both ROS1 fusion will respond to the current drug approved for ROS1 translocation. But this is the most peculiar case that we've seen so far. This patient actually initially was diagnosed with lung cancer and has sensitizing mutation on EGFR, so exon 19 deletion, and was put on afatinib, but only responded for 5 months and developed resistance. So we got the FFP from patient's resistant tumor, and we performed. So this is a conical biopsy. So when we sequenced this particular patient, what we found is that the original sensitizing EGFR mutation is still there, exon 19, and actually present at very high allele frequency. So how come this patient doesn't respond to EGFR TKI? Because his EGFR is also amplified. So if you look at the copy number alteration, you can definitely see that this patient does not only have EGFR mutation, but his EGFR also is amplified. So this is actually not surprising. Sometimes under the drug treatment, you develop resistance by amplifying the drug target. But the most peculiar thing is that we also find translocation. So this patient, in addition to EGFR mutation and amplification as primary driver, the patient also had EML4 ALK fusion. 2 driving mutation present at the same time. And so the oncologists think that, well, it would be too financially toxic for the patient. So he decided to first treat the patient with ALK inhibitor. The tumor doesn't respond at all. So finally, the doctor decided, okay, might as well combine both targeted therapies to hit both driver pathways. The patient responded quite well. And before, we never thought that on the same tumor, you will have 2 different driver mutations present. And typically, when we look at EGFR mutation, if you find a patient with EGFR mutation, you probably will never bother look at other pathways. But this is actually clinical samples that we faced in our company. So these are some examples that even a larger panel will be very helpful for more sensible to treat to select the treatment option for the patient. And in addition to guide patients' treatment selection, tumor-associated mutation is also a very good marker to allow oncologists to monitor their patient either for residual disease or for disease recurrence or for disease resistant mutation. So I'm not going to go through the advantage and disadvantage between liquid biopsy versus solid tumor tissue, as well as the characteristic of these samples. But I think ctDNA is actually a very good to allow us to monitor patients' tumor. But you can have many different methods to develop to detect circulating tumor DNA. So you can either go for those methods that has extremely high sensitivity, but can only detect a few mutations in the same test, or you can go for those tests that has reasonable sensitivity and allow you to monitor multiple genes at the same time. And so next generation sequencing actually is the method that allows you to get enough sensitivity, yet allows you to at least monitor hundreds of genes at the same time. So this is the type of assay that we consider probably would be most appropriate for monitoring disease. And even though you can go for a lot of genes, but in fact, for monitoring cancer patient, particularly lung cancer patient, since you need to go for very, very deep sequencing, so our panel was designed to monitor disease, and we typically will only sequence patients for a couple of genes that will cover about 80% of lung cancer patients. But even with such a small panel, it can still cover all of those alleles that will confer resistance to all of the current treatment options. So to cover all of the EGFR resistant allele, all of the resistant allele for ALK inhibitor, as well as BRAF, MEK, and MET inhibitor. So you can, based on the mutation detected in the patient's blood, to decide which drug will be the next treatment option. So here's some example that we have in our lab. So these are 23 non-small cell lung cancer patients. These are our patients currently receiving therapy. And so you can see that quite a few patients actually has EGFR mutation that can be detected in their blood. So 14 out of 23 patients actually have detectable mutation in their plasma, and 12 of them have EGFR mutation. Out of these 12, actually 2 of them has EGFR T790M mutation. And you can look at the ratio between, for example, sensitizing mutation and resistant mutation. So for the second patient, virtually every cell become resistant. So this patient has to be switched to third generation TKI because virtually all of the tumor cells become resistant. But even for those patients who doesn't have EGFR mutation, so for example, the third patient, we did not detect any EGFR mutation in the patient's blood, and actually this patient's tissue is EGFR negative. But you can still detect, for example, KRAS mutation in the patient's blood. So if we want to follow the patient's tumor burden, we can follow the patient by tracking the KRAS G12V mutation. So if the G12V mutation allele frequency goes down or goes up, we can use that as a reflection of tumor burden. And in fact, in addition to plasma sample, we can also use CSF if the patient has brain met. And we actually have quite a few examples, particularly when patients develop brain met, and we sample the blood as well as the CSF. And in one patient, we actually found that in the blood, the patient has T790M mutation, but in the plasma, the patient actually, in the CSF, there's no T790M. And that makes sense because first generation TKI doesn't penetrate brain too well. So the cells in the brain should still be sensitive to first generation TKI, but how come it doesn't respond? Because that tumor actually has MET amplification in the brain. So for the same patient, you sequence the peripheral and you sequence the CSF, and you can tell that at different region, the tumor responded differently to the current treatment. And with that information, the oncologist can better design a treatment option. And so one of the patients actually was treated with a MET inhibitor, and the brain met was controlled pretty well. So before, we never thought of the possibility that even liquid biopsy from, for example, polite fusion supernatant or from CSF can be used to monitor the patient. But now with the technology available, I think the lung cancer patient, when they are initially diagnosed or when their disease progresses, we do have a lot more weapon to do to make the better treatment selection based on their genetic alteration. So I think since I believe that everyone is hungry, I'm just going to stop here. And thanks for listening.
The patient has poor fluid as well, and of course, if we can also take the blood for ctDNA. So which do you prefer? Do you want us to send both or one of them?
Actually, polar fusion, it contains both cells and also supernatant. So if possible, the best option would be to spin the cell down to prepare cell block, and so that we can make sure that there are tumor cell in the tissue, that in the cell block, that we can proceed to sequence. And in that case, the data will be much better compared to supernatant, because for most of the liquid biopsy, there's one uncertainty. We don't really know whether there are tumor DNA in the blood. But with tissue sample, we'll be able to see it, because before we perform the sequencing, we always have pathologists look into the tissue or into the section. And for all of the FFP sample, if possible, we will perform macrodissection. So for tissue sample, as well as those samples that you can perform enrichment, your chance of detecting amplification is much higher compared to, for example, plasma sample. Plasma sample is good for detecting point mutation, but the ability to detect amplification. So for example, if the patient's resistant mechanism is MET amplification, you can detect that in the tissue, but there's no chance to detect that in the plasma. So if there's possibility, then cell block will be the first choice. If that's not available, then we will go for polar fusion. And the last option will be plasma.
So if the pool fusion doesn't contain any tumor cells, so
we typically will do both. So if the polar fusion doesn't contain tumor cell, we actually would not perform sequence at all. So we know beforehand that there's no tumor cell in it, because oftentimes you get the data back and it's negative data, but you don't know whether it's because there's no tumor, or whether it's that tumor doesn't release DNA, or the tumor doesn't have the mutation that you want to detect. But at least when you look at the section, you have already excluded the first possibility. You make sure that there's tumor in it.
okay, thank you. So any other questions?
I previously worked at PY. Have little experience looking at the EBUS TB&V. Usually the tissue sample is so limited. It's very hard to make a definite diagnosis, not mentioned to do the extra genetic studies. To your experience, is obtaining tissue, is it operator dependent? Is there any please forgive my ignorance, because I really don't know from my previous experience. The tissue is so limited.
Thank you for your questions. In fact, it is a hot topic. Small biopsies, but do a lot of investigation in this biopsies. This biopsy specimen is getting smaller and smaller, but the requested test is asking for more and more tests. This is a real world, and it's what's going on. I would say that it's after all, it's skill dependent, and also in the past, for example, as I said, for Foundation 1 we did 15 slides. So if we know beforehand, we have to do send tissue for Foundation 1, if we have to take a lot of the tissue samples. So the operators have to know that the target areas, whether it's possible to do these biopsies. If it's possible, then we have to try to aspirate as many times as possible. In the world of the interventional pulmonologists, they said that only 2 or 3 little parts is good enough based on certain clinical trials. But for my practice, I would take 8 or 10 biopsies. So that may be the difference. And also, even within one little biopsies, the technique is also important to make sure every little samples has retrieved a lot of adequate tissues. So technique is important.
Do you think FNA is wrong?
Well, basically, there are many different choices of needles nowadays. In the past, there's only one, but we have a Boston, and we have also another company. I can't remember the name, but basically, we use a 22 gauge. I use only 22 gauge needle. I tried 21 biggest needles, and the biggest needle, 19 gauge needle, is coming in the market, but so far, what I have done for the past 12 years, I use a 22 gauge needle is enough for all these requirements.
Thank you.
So any further questions?
Actually, I would like to add one point that if it's possible, definitely co-needle biopsy is the best. But if it's not, then even fine needle biopsy or fine needle aspiration, if you do have enough cells there, it should be feasible for conducting even tests like next generation sequencing. We, in fact, have a lot of sample all coming from Hong Kong that has just couple of hundreds of cells that you can actually see how many cells in the blood. But some of the tests can actually be performed using very limited quantity of DNA and RNA. Now we do have technology to extract both DNA and RNA from the same sample for mutation, for amplification, deletion, as well as for translocation. But those very tiny sample definitely would not be enough for a large panel. But for smaller panel, like 35 genes, 50 genes, that's still quite feasible.
So any further questions? So if no, then I think we'll call an end to this symposium. So let's John, souvenir.
Yes, we've got some souvenirs for the speakers and the chairperson as well. I would like to ask the Dr. Ao, okay. Dr. Wong, Dr. Chen, and then Dr. Lee.